The heights that great men and women have reached and kept were not attained by sudden flight, but they, while their companions slept, were toiling upward through the night. So, let's get to work. Well, we're in uncharted waters today, and typically I like to include case presentations in my lectures for several reasons, and I'll talk to you about that in just a minute. But at least what we're going to do today is I am going to include the case presentations, and although you're not here to discuss these with me, you will have access to this, obviously. And then 1 or 1.5 weeks after that, I will send you the answers so that you can email me at that address, and we can converse about what you think is right or wrong about my presentation or my answers. Well, the first presentation that we have today is a 50-year-old Caucasian status post total abdominal hysterectomy, bilateral salpingo-phorectomy for severe endometriosis with bilateral 6-centimeter ovarian endometriomas and pelvic implants and omental endometrial implants. She has severe hot flashes and night sweats. She's very healthy without a history of heart disease, without a history of osteoporosis or breast cancer, and she has no significant family history. Her lab data, including lipids, are normal. Now, this patient is presenting to you, and what are you going to do with this patient? Well, just to get you started, she is without a uterus, so that might alleviate some of your concerns. But this patient has had severe endometriosis. It's about the worst case of endometriosis that I have ever seen. Are you going to put her on estrogens? Are you going to put her on androgens? Or are you going to put her on progestogens? Or a combination of those? Okay, well, let's dive into this problem of the treatment of the menopausal patient with hormones. I don't know of any area, of any arena of gynecologic medicine that is more complex, that is more ambiguous, that is more nuanced than the attempt to treat the menopausal patient with hormones. There are a variety of different opinions. Now, what I have in front of me here is one of the premier prominent medical journals in this country today. I'm holding it up. You can't see it, but it is The Economist, somewhat similar to Time Magazine or Newsweek, only it's produced in Britain. Now, in the December issue of The Economist, it states, millions of menopausal women are missing out on the benefits of hormone therapy. Okay? Now, in January of this year, I have a later edition of The Economist, and there are 2 letters to the editor, one from the medical center in Colorado and one from a medical center in Philadelphia. And in both of those letters, they state that there is no justifiable reason that a woman should take hormone therapy, and it does not save lives. Well, the United States Preventive Services Task Force has recommended that women not take hormone therapy. The American College of Physicians states, not quite so emphatically, that women should not take hormones for the prevention of osteoporosis. And so, what am I supposed to stand up here and tell you as students what you should do when you've got such a variety of opinions? Well, let's try to tease through some of this evidence and see if we can come up with an answer. I think I have the right answer. I can assure you there will be people who disagree with what I say. The purpose of this lecture is multifocal. I think this is the most important slide that I'm going to show you today because all of the other slides that I'm going to present to you are information that you have access to with your chapter on the menopause or the position statement from the American College or the position statement from the North American Menopausal Society. But what I would like to reiterate to you, and hopefully I am reiterating something that other professors or other physicians have told you, and that is to do the very best that you can to practice evidence-based medicine. Start with the randomized controlled trial. The best attempt that we have to eliminate biases such as selection bias, which is what caused some of the problems that we've had in the past with treating the menopausal patient. Now, you start with the randomized controlled trial, and then you go down to the prospective cohort study, then the retrospective cohort and case control studies, anecdotal information, and then expert opinion. Now, we have not always practiced evidence-based medicine. I can assure you from firsthand information that when I was a resident at Stanford University in obstetrics and gynecology, we treated patients in preterm labor with intravenous alcohol in an attempt to stop them from delivering their baby. Now, that was predicated on retrospective studies. Fortunately, within the next year, there were randomized control trials that showed that that was not efficacious, and certainly the risk factors were there. I have woken in the middle of the night wondering what happened to those fetuses that I treated with intravenous alcohol. Now, there's no question that a lot of infants have been exposed to a lot more alcohol than what I gave. Well, sometime in the late 80s and early 90s, the American College and other professional organizations made a big push to try to get doctors to practice evidence-based medicine. And for the most part, they do, but today, still yet, there are many clinicians that do not do that. There are clinicians in this community that will take salivary tests and have the lab look at the estriol levels, the estrone levels, the estradiol levels, the progestogen levels, maybe the androgen levels, and I don't know what. They'll have pharmacists to concoct formulations and then give those to the patients. The American College of Obstetrics and Gynecology, the NAMS, have all stated that this is not good practice and you should not prescribe bioidentical hormones, but still yet they do that. Now, please forgive me, but just parenthetically for 60 seconds or less, wouldn't it be great if we could extrapolate this concept of practicing evidence-based medicine into the general public and having the public practice evidence-based decision-making? In other words, have them practice evidence-based decision-making regarding buying a home or buying a car or electing a president. Would that not eliminate a lot of the fake news, a lot of the obfuscations, a lot of the downright lies? Another purpose of this talk is to get you to pass your OBGYN boards or whatever boards you're going to take. Approximately 15% of first-time takers who try to pass their OBGYN boards do not pass. And I think that there's a good reason. I think that most of the people have the functional knowledge and the facts. I just don't think that they can make a cogent presentation to 3 oral examiners during the examination. And so that's why I put these case presentations in my lecture. And I would encourage you throughout your medical school and in your residency programs to try to do as much as you can interacting in case presentations. It'll allow you to, it'll facilitate the oral examinations when you have to present a cogent presentation regarding the differential diagnosis and the justification for why you want to treat a patient like you should. One other purpose is to avoid the liability problems. I think there's two things you can do. We've already talked about one of those, and that is to practice good evidence-based medicine. I think the second thing that you can do is to include the patient into the decision-making process. And what I mean by that is when you have a patient come into your office, you do a history and physical on her, and then afterwards you sit down and talk to her and present your treatment plan. Then she leaves and you write down in your chart, PAR, procedure, alternative, and risk. You've explained to the patient the procedure or the treatment you're going to do, the alternatives, and the risk. And then under that, write, the patient has decided that she wants treatment X. And I think if you do both of those things, you'll substantially reduce the chances of you being involved in a liability problem. And you are going to have problems and you are going to have complications. I can assure you I've had almost every complication you can think of, and I've had some problems. I have not been in the courtroom for myself. Never stop learning, be humble, and if there's time at the end, I'm going to present an anecdotal story which is somewhat embarrassing to me, but I'll tell you anyway. I do not have any conflict of interest. In the past, I have gone around the country talking about birth control pills and hormone therapy, but I do not do that now. Okay, what I want to do now is go over a little bit of the history of the hormone therapy for women in the menopause so that you can understand better how we got into the position that we are in now. Way back in the 1930s, everyone knew from epidemiological data that women were somewhat protected against coronary artery disease, myocardial infarcts, compared to their male counterparts. In other words, there was about a 10-year delay when a woman would be as likely to get a heart attack as a man. And that continued up to the menopause, and after that, then the women rapidly approached the men in the incidence and prevalence of coronary artery disease. So everyone had a good idea that it was probably related to the estrogen levels. Well, sure enough, they then had two large retrospective studies, the Framingham study and the Her study, where they put women on Premarin, which is a conjugated equine estrogen. There's 21 different estrogens that are obtained from the urine of mares, from horses. That was in combination with medroxyprogesterone acetate, the progestational agent, and they knew then that they had to put a progestogen in to make sure the unopposed estrogen didn't lead to endometrial cancer. This was a retrospective study, and unfortunately, it was biased, and there was a selection bias. All of those women who came into the doctor and were put on hormones were in better health. They weren't as likely to smoke. They had their blood pressure controlled. They had their cholesterol controlled compared to an awful lot of the women who didn't. And then, obviously, the results of this study showed those women that came in to see the doctor had a reduced incidence of coronary artery disease. Well, throughout the country, including myself, clinicians gave women Prempro or a similar drug, and women were really happy. They felt a little bit better, and they thought they were doing themselves some good. Well, sure enough, along came in 2004 the Women's Health Initiative. Now, this was the first randomized controlled trial that evaluated the treatment of women in menopause with hormone therapy. And what happened was, after about 4 or 5 years, they noticed that women who were on hormone therapy, including estrogens and progestogens, the Primpro, those women had a substantially increased risk of coronary artery disease, myocardial infarcts. This was statistically significant. And likewise, there was an increased incidence in breast cancer. And this was statistically significant also. They stopped this study immediately after 5 years because of this increased incidence of heart disease and breast cancer. Well, guess what? I had a lot of people call me and say, Dr. Keyes, I don't want to stay on my hormones. I read that it causes heart attacks and it causes breast cancer. And I said, well, I understand exactly what you're concerned about, and I agree. And so they came in, and we sat down and talked about the risk and the complications, and we tried to substitute other drugs, SSRIs or whatever. Well, a funny thing happened about 2 or 3 months later. All of a sudden, I started getting a whole bunch of calls from women that had stopped their hormones, and they say, Dr. Keyes, I don't care whether these hormones increase the incidence of heart disease or breast cancer. I want to go back on my hormones. Obviously, the quality of life issues were really important. The postcoital bleeding, the dyspareunia, the hot flashes, the dryness around the vagina. So I called these women back in and said, well, okay. I sat down and discussed the risk and alternative things that we could do. I put an awful lot of women back on hormones. Parenthetically, you should know that after the Women's Health Initiative came out, an awful lot of women stopped taking hormones, and within a very short period of time, there was an increased incidence of osteoporotic fractures, and we're going to talk about that in just a little bit. So it didn't take long, but about 6 months later, another evaluation of the Women's Health Initiative was done by the epidemiologist. I don't know of any study in gynecologic literature that has been re-examined more times than the Women's Health Initiative. And what they found out was that the estrogen arm alone in that study, in other words, those women who didn't have a uterus who were placed on estrogens alone, those women had a statistically significant reduction in the incidence of coronary artery disease, heart attacks. Also, they had a reduction in the incidence of breast cancer. Now, that decreased incidence in breast cancer was not statistically significant. However, epidemiologists thought that if that study would have been continued, then it would have attained statistical significance. So here we are. What are we going to do? Well, let's try to tease through this and see if we can figure out an answer. Well, what is the menopause? Well, the menopause is a retrospective diagnosis, isn't it? It's made when a woman hasn't had a period for 12 months. If she hadn't had a period for 6 months, she's not menopausal yet. She could still ovulate. She could possibly still get pregnant. After 12 months, you can look back and say, this woman is now menopausal. The average age of menopause is 51.2 years, plus or minus 3 days. I hope that there was at least some giggles with that. What is the perimenopause? Perimenopause is that time period before that last menstrual period. Differing studies have different amounts of time, somewhere between 2 and 5 years, some only 1 year. What happens is there's a waning level of estrogen that occurs, which causes the menstrual periods to become further and further apart, less and less bleeding. A woman will bleed every 2 months, then every 3 months, and 4 months, finally every 6 months, and then that last menstrual period. Also, the bleeding will be less. This is a function of the decreasing level of inhibin produced by the granulosa cells in the ovary. And this decreased level of inhibin has a negative feedback mechanism on the follicle-stimulating hormone produced by the anterior pituitary gland. So as the inhibin levels go down, the FSH levels go up in an attempt to increase the production of both inhibin and estradiol by the granulosa cells, and also an attempt to get a woman to ovulate. She also has decreasing ovulatory cycles, but basically there is a decreasing level of estrogen. So what are the hormonal changes that occur? Well, we just talked about one, and this might be a question on your examination. What is the first biomarker that goes down in the perimenopause? And the answer is inhibin. And then inhibin has that negative feedback, so the FSH levels go up, the LH levels go up. Obviously, there's less ovulatory cycles, and so during the proliferative phase of the endometrium, there's less estradiol produced, and then there's less ovulation, so progesterone levels go down in general. Okay, well, let's talk about the complications that can arise during menopause. First, we have vasomotor instability, hot flashes and night sweats, urogenital atrophy, primarily atrophic vaginitis, osteoporosis, coronary artery disease, possibly dementia, and then the quality of life issues that we alluded to earlier. Well, the first one is vasomotor instability. This is a major disruption in the quality of life for women. I don't want you to think of it as only a cosmetic problem really in comparison to other problems such as osteoporosis or coronary artery disease. What exactly is it? Well, it's a sensation almost of a headache, and then this intense sensation of heat in the upper chest that radiates up through the neck into the head. A woman will become sweaty. She has palpitations. She has vasodilatation. The core body temperature goes down. It's caused by a decrease in the thermoregulatory center in the hypothalamus. And you're going to have to talk to a neurologist or a pathologist to find out exactly what that is, because I do not know. There are decreasing levels of estrogen, and there's also an LH surge. It's not caused by an LH surge because women who have had a hypophysectomy also get hot flashes. It's associated with an LH surge, though. They also get night sweats, they get moodiness, they get sleep disorders. Symptoms can last for several years, up to greater than 10 years. Now, the treatments are decreasing alcohol, decreasing caffeine, turning the temperature down, and there are multiple studies that show that SSRIs, serotonin reuptake inhibitors, have some beneficial effect. I have not had that much luck using those. Estrogen is the treatment of choice. It will almost completely eliminate hot flashes. It certainly substantially reduces the frequency and the severity and the intensity of that hot flash. And just to point out that this is not just a cosmetic problem. What if this woman comes and presents to you and she's having hot flashes, she's having regular periods, she's 50 years old, and you don't really feel like she needs to go on estrogens, but you're going to put her on an SSRI to help her. She comes back in a month and she says, well, she thinks she's a little bit better, but she's still having hot flashes and she has night sweats. She's not getting any sleep. She's exhausted. So you say, well, let's give it 2 more months try with these SSRIs. And next month, you read in the newspaper that this woman who was totally exhausted, went to work, came home from work, and crossed the midline and ran into a car and killed 2 kids. Well, it's just something to think about. Estrogens are by far the best treatment. They're approved by the FDA for vasomotor instability. And then we have vulvovaginal atrophy, genitourinary syndrome. This affects all of the pelvic organs, primarily the vagina. The vagina loses its rugae, it becomes smaller. You can see the capillary vessels in the vagina. If you touch the vagina with a Q-tip when you're doing a pap smear, it will bleed, consistent with having postcoital bleeding. There is an increased pH in the vagina because there's not as much glycogen, and a decrease in the lactobacilli. With no lactobacilli and an increased pH, there's an invasion of Bacteroides, Peptostreptococcus, and Streptococcus. Then you get a gray discharge. Once again, the primary reason is the waning levels of estrogen. You can do a maturation index test, taking a swab of the vagina and send it to the lab. There will be a disproportionate reduction in the epithelial cells compared to the basal cells and the parabasal cells. 84% of women will be affected by this. There's also an increased incidence of urinary tract infections, dysuria, frequency. The treatment, once again, can be lubricants, moisturizers for painful intercourse. But once again, I have not had much success with those. And the best treatment of all is estrogens. They are approved by the FDA for the treatment of atrophic vaginitis. Well, maybe the most important problem associated with the menopause is osteoporosis. Osteoporosis is a decrease in the bone mineral density and a deterioration of the microarchitecture of the bone. Now, once again, you're going to have to ask your pathologist or your orthopedic surgeon exactly what the microarchitecture of the bone is. I do not know. There's always a buildup and tearing down of the bone. It's reforming all the time. There's a balance between the osteoclastic activity, which tears the bone down, and an osteoblastic activity, which builds the bone back up. Now, during menopause, when decreasing estrogen is there, somehow that causes an increase in the osteoclastic activity over the osteoblastic activity, thus leading to a decrease in bone mineral density and likewise to a decrease in this microarchitectural. Now, one thing that's really important in the development of osteoporosis is the peak bone density, because at any level, at any time, it's related to this peak bone density, because that's where you start from. In women, that peak bone density is about 20 years old. In men, it's about 25. And from there, it goes slowly, gradually down. But then during the menopause, you have a substantial reduction in estrogen, so you have a big loss in this bone mineral density. And at menopause, a woman can lose 5% of her bone mineral density for every year up to 5 years. Left untreated, a Caucasian woman can lose 50% of her bone mass over 20 years. Now, don't forget that. That's going to be really important when we talk later about how long we're going to treat women with estrogen or whether or not we're going to treat women at all. I see I'm getting a little short on time, and so I'm just going to tell you that the vertebral fractures are significant. They cause severe pain and loss of height. The woman can lose a centimeter for every vertebral fracture that occurs. 15% of Caucasian women will have Colles fracture, and the most dramatic and important is the hip fracture. 80% of all the hip fracture associated with osteoporosis. And the modifiable risk factors are, obviously, the big one is the decreased estrogen, smoking, excess alcohol, sedentary lifestyle, and then calcium and vitamin D. Now, aerobic exercise is not what prevents osteoporosis. It needs to be weight-bearing exercise. DEXA scans are the way you diagnose osteoporosis. Greater than a minus 2.5 bone mineral density measured by standard deviations below normal is osteoporosis. Between minus 1 and minus 2.5 is osteopenia, and there's a lot of discussion about whether osteopenia should be treated. You treat with decreasing tobacco, alcohol, use weight-bearing exercises, and calcium and vitamin D, and obviously estrogen. Estrogens not only can prevent bone loss, they can treat it a little bit. If you treat a woman with estrogens alone, there's an 85% reduction in the chance you'll ever have an osteoporotic fracture. If you add calcium and vitamin D, 1,500 milligrams of calcium and 1,000 international units of vitamin D, then you're going to reduce the chances of that woman ever developing an osteoporotic fracture by 90%. Now, I don't want you to memorize this. There's only one thing at the bottom of the slide I want you to memorize. Just read it with me. 50% of women over 50 will experience an osteoporotic fracture. Caucasian women account for 71% of osteoporotic fractures and 75% of all the cost of osteoporotic fractures. Afro-American women are less likely to get osteoporotic fracture, and Asian women are in the middle. 10 million American women have osteoporosis. Aging population will lead to an increased prevalence, and the most important thing on this slide is it is going to be a massive public health problem for you and your colleagues to take care of. Okay, I just want to talk to you a little bit about why estrogens prevent coronary artery disease, as we talked about in the Women's Health Initiative. There's probably two reasons. First of all, estrogens affect the HDL, the high-density lipoproteins, and the LDLs. They raise the HDLs and lower the LDLs, and you're well aware that that is conducive to the reduction in coronary artery disease. Likewise, estrogen increases the nitric oxide in the endothelial cells of the coronary arteries, and this causes vasodilatation, affects the macrophages, the cytokines, and maybe other things as well. The same thing is true for dementia, in that we think from some studies that show a marginal improvement in the reduction in Alzheimer's disease or dementia if a woman is placed on estrogen. And for both the coronary artery disease and dementia, what's really important is that a woman be placed on estrogen at the time of menopause, during that 10-year critical time. If you wait until after that, if you wait until high blood pressure or high cholesterol, or when there are amyloid deposits on the neuron, or those neurofibrillary tangles, whatever that is, once that has developed, then the estrogens do not work, and in fact, they may make it worse. So it's to prevent the coronary artery disease, and it's to prevent the dementia. You start them on it immediately after the menopause. Now, I just want to say one thing, that everything I'm telling you is predicated on the Women's Health Initiative, one or two other studies, but all of this information changes at the age of 70. And the risk-benefit ratio becomes much more equal. And when you talk to a woman about what she may want, you're going to have to introduce the quality of life issues, and the risk benefits stay the same. Okay, I just want to briefly talk to you about the rectangularization of life. I hope you've heard this before. On the x-axis is the years, on the y-axis is the health. And all of those problems that are associated with older age, like loss of hearing, loss of vision, loss of cognitive ability, osteoporosis, coronary artery disease, what we would like to do is postpone those from happening earlier so that it becomes more of a straight line and approaches the lifespan of a human. Each species has a lifespan, and humans' lifespan is about 84, 85 years old. So if we could lift that curvature of that line up with estrogens and preventing those diseases so that a woman lives to be 84 years old, and then on January the 1st, she has a stroke, a heart attack, falls and breaks her hip, and dies. This just shows you that there's going to be approximately 300,000 more women that you're going to have to take care of once you finish your residency. Likewise, the life expectancy, not the lifespan, but the life expectancy has increased. The age of menopause has not increased. And so now a woman can expect to have 1/3 of her life during the menopause, and you're going to have to take care of her for that. We've already reiterated that estrogens and progestogens increase the incidence of coronary artery disease and breast cancer, and estrogens alone decrease both the coronary artery. I'm not going to spend any time on the progestational agents. All right, here we are. Maybe this is the most important slide I'm going to talk to you about with the idea of what we're going to do. We have this conundrum of how to treat a woman who's got vasomotor instability, urogenital syndrome. We know that estrogen will prevent hot flashes. It will prevent atrophic vaginitis. We know that if we treat women with estrogen plus calcium and vitamin D, we can reduce the incidence of an osteoporotic fracture by 90%. We also know from the Women's Health Initiative that we can substantially reduce the incidence of coronary artery disease, probably breast cancer, and then dementia, maybe. And there's no question we can improve the quality of life for a woman by putting her on estrogen. Now, the problem is, if you've got a woman that's got a uterus, what are you going to do? If you put her on just estrogen, which will definitely prevent all of these problems, then it's going to increase the chances of her developing endometrial cancer. So you're going to have to sit down and talk to her, and your different recommendations. Some people say treat women with the lowest dose possible for the shortest time period possible, 10 years or less. But don't forget what we just looked at a while ago. If a woman has not been on estrogen, then within 15 years, she will be at the same risk of developing an osteoporotic fracture as if she'd never been on it at all. So if you put her on estrogen at 50 and stop it at 60, at 75, she's going to be at that same risk. When do women get osteoporotic fractures? At age 75. Well, let's talk about something else you could do. What about putting this woman on unopposed estradiol and performing an endometrial biopsy once a year? Let me just tell you that endometrial cancer is very similar to cervical cancer. You're well aware that cervical cancer caused by human papillomavirus takes 10 years or longer to develop. It goes through mild dysplasia to a moderate dysplasia, severe dysplasia, carcinoma in situ, and cancer. Likewise, endometrial cancer goes through normal cystic hyperplasia, complex hyperplasia, and complex hyperplasia with atypia before it gets to cancer. And it probably takes 3, 4, 5 years for that to develop. So if you do an endometrial biopsy once a year, I contend that you're going to reduce the chances of that woman ever getting endometrial cancer to less than what it would be if you put her on an estrogen and a progestogen. Now, don't forget, endometrioid cancer is not the only cancer of the uterus. There's clear cell cancers, and progestogens aren't going to reduce the chance of that. But if you put her on unopposed estrogen to do a biopsy, it might. I am concerned that we're not going to have enough time to do these case studies. Maybe I can come back in just a few minutes. I want to tell you that this lecture was supposed to talk about sexual dysfunction. I just don't think that we had enough time for that. I will tell you that 60% of all sexual dysfunction is going to be related to atrophic vaginitis, deep dyspareunia or dyspareunia, and we've already talked about that extensively. I will tell you that another 20% is going to be related to pelvic inflammatory disease and or endometriosis with deep dyspareunia. And the sensitivity and specificity of all of the tests that you're going to do and your clinical exam is not going to be very good. And what you want to do is refer this patient or do it yourself, perform a laparoscopy, and see if she has endometriosis or pelvic inflammatory disease. 20% will have hypoactive sexual desire disorder, and I have personally seen one case of vaginismus in my career. Okay, I just want to tell you briefly about that case of vaginismus that I saw. And I am not a psychiatrist, and I had a patient that was approximately 35 or 40 years old. She came in, and every year she came in, I had an unbelievably difficult time examining this patient. If I touched her vagina, she had an involuntary contraction of all of those muscles, and it was very difficult. Allegedly, according to her, she was having sexual intercourse. Over the next 3 or 4 years, she would come in. We gave her Valium, we gave her pain pills, a combination of both. I was laying in bed one night thinking about this, and so the next time this patient came in, what I did is I got an ice pack and had the nurse put an ice pack on her perineum and left it there for almost as long as she could stand. It worked. I was able to perform a pelvic exam. Now, you won't find a study on this anywhere. This is just an anecdotal experience that I had that worked, and I wanted to tell you about it. I just want, once again, to parenthetically include in this talk just a little bit of information about what the medical schools on the East Coast and at Stanford University are teaching their students. They are teaching their students not only to take care of their patients, but also to take care of the planet. And that indirectly takes care of their patients. Now, you are going to be unbelievably well educated when you get through with your residency. You had an undergraduate career in zoology and chemistry and physics like I did, or something comparable. You've gone to medical school, you're going to do a residency, and you're going to be in the upper 2 to 3% of the population as far as functional knowledge. And you're going to have to address some problems. Do you realize that right now, 35% of the people in this country do not believe in evolution? 35% of the population in this country do not believe that humans are responsible for global warming, that we have a problem with overpopulation, that the underground aquifer beneath The Ogallala aquifer beneath Texas, Oklahoma, and Kansas is 50% depleted. Do you realize that 35% of the people do not think that a woman has a right to an elective abortion? You're going to have to address these problems and educate people about the problems that we're going to have. We're going to have some serious ethical issues in the near future that you, as students, are going to have to take care of. With CRISPR and gene editing and eugenics coming along, there's going to be some very serious ethical issues. Well, I just want to present one question for you that you might ask me. I was trying to think of a question that you might ask. And with reference to doing endometrial biopsy, maybe you have already heard that if you do an ultrasound on a patient and the endometrial lining is less than 4 millimeters in thickness, then that patient will not have endometrial cancer. Could you do that instead of the endometrial biopsy? Well, I'm just going to tell you that probably you could. But myself, I would prefer to have that pathologic diagnosis so I could see if there were early changes like cystic hyperplasia or complex hyperplasia before it got to almost cancer. So I'm hoping that you have other questions since we weren't able to do them today. And finally, I'm just asking the question to you, is there any of you that are interested possibly in going into obstetrics and gynecology? And I want to tell you that if you are, I can assure you that I absolutely loved it and I would do it again in a heartbeat. I used to go to Tahiti on vacations and I loved the first day. I absolutely enjoyed the second day, snorkeling with sharks and looking at coral reefs. On the third day, I was ready to come home and do a hysterectomy or do an emergency cesarean section at night. If you are interested in an academic career in obstetrics and gynecology, as I alluded to earlier, I did train at Stanford University, and I don't guarantee you a passage. But if you're doing well and if you have the right attitude, well, don't hesitate to get in contact with me. And possibly a letter from an alum might be the tipping point. Thank you, and bon voyage.